My name is Abbas Anwar. I'm one of the general ENTs here at Pacific Head and Neck. I'm excited to be here. Thank you all for coming. I think we'll get everything started with I think a very relevant topic in today's day and age, and that's olfactory dysfunction in COVID-19, which I think we as ENTs are seeing pretty frequently, but I'm sure is being seen a lot more commonly in primary care offices. No financial disclosures. So just an overview of what I'll be talking about. First, I'll be going over the incidence and duration of COVID-19 associated olfactory dysfunction. I'll quickly go over the pathophysiology of COVID-19 associated olfactory loss, and then the bulk of my talk will be about the evaluation and treatment options available to these patients. So, in terms of the incidence of olfactory symptoms, most COVID-19 infections, at least at the beginning of the pandemic, resulted in at least transient olfactory dysfunction. And olfactory dysfunction is defined as hyposmia, which is a decreased sense of smell, anosmia, which is an absence of smell, and parosmia, which is distortion in your sense of smell. And so in an article back in 2021, around this time a year ago, a meta-analysis showed olfactory dysfunction was present in 48% of patients with COVID-19. Interestingly, 45% of them subjectively reported it, but when we tested these patients, actually 72% were objectively measured to have some olfactory dysfunction. So some of these patients aren't even aware that they have some olfactory loss. That study also interestingly showed a female preponderance, 61%. But fortunately, smell and taste dysfunction has become less common among the more recent variants, including Omicron. We've been seeing less and less of it with patients that have been infected with the more recent COVID-19. One study looking at 486 Omicron cases found only 8.3% of patients had olfactory dysfunction. And we're not exactly sure why there's less incidence of olfactory dysfunction, but it might be due to previous infections or vaccinations. It could also be due to the fact that the variant might be having a milder inflammatory reaction at the olfactory epithelium. So in terms of the duration of olfactory symptoms, fortunately, it tends to be relatively short-lived in most patients. Anosmia related to COVID-19 typically has a duration of 8 to 9 days, and 85% of patients will recover their sense of smell within 6 months, and 96% of patients within 1 year, according to one study in 2021. So it is about the 5 to 10% of patients, though, that will have olfactory dysfunction longer than 6 months, and those are the patients that we see in our office very frequently. The intensity and duration of the olfactory dysfunction is highly variable and appears to be dependent on the capacity and rate of regeneration of the olfactory neuroepithelium. So in terms of the pathophysiology, COVID-19 related anosmia likely is related to intranasal inoculation of the virus into the olfactory neural circuitry. This is a schematic of the olfactory epithelium. So the olfactory epithelium sits in the back of the nasal cavity, kind of towards the top. And what this shows is the olfactory epithelium has tiny little cilia that are kind of emitted from the epithelium, and this is where the odorant molecules attach, and they deliver that information through these olfactory axons or neurons, and that's where it hits the olfactory bulb and then is sent via the first cranial nerve to the brain. So the mechanism of entry into the CNS is a little bit unclear, but what we think is happening is that actually the virus is getting into the supporting cells, so not the actual axons, but the supporting cells called the sustentacular cells. And once it enters these supporting cells, it ends up destroying them. And without these supporting cells, the olfactory neurons deteriorate, and that's where we get the olfactory dysfunction. So why does this matter? Well, olfactory dysfunction is really, it's a disability. It can be dangerous. people can't smell their spoiled food. If there's a fire in their house or their apartment, they can't smell the smoke. If there's a gas leak, they can't smell it. So this is relevant in that terms. But I think, more practically speaking, it can definitely lead to depression. It's something that we see in the office a lot. Olfactory loss is associated with depression, and there are neuroanatomic connections between the olfactory and limbic systems. So whenever I see a patient with long-term olfactory loss, I do like to acknowledge that, that it can cause depression. I like to acknowledge their feelings. Some people are even a little bit embarrassed to, feel a little bit depressed about this, but it's a true thing that happens to some of these patients. And so, we're trying our best to help them out there. In terms of causes, the most common causes tend to be inflammation within the nose. So that's things like rhinitis, whether it's allergic or non-allergic, sinusitis. There's also post-traumatic and post-surgical. A lot of endonasal skull-based surgeries can cause at least temporary smell loss. There's neoplastic reasons that can lead to smell loss. There's certain tumors that can occur near the olfactory epithelium, like olfactory neuroblastomas and meningiomas that can cause smell loss. Neuroinflammatory, olfactory dysfunction can be one of the earliest signs of Alzheimer's disease, so that's something to be aware of. But at the same time, olfactory dysfunction can be a normal part of aging, so it's something that we see in a lot of older patients. There are even congenital reasons to have olfactory loss. One of them is Kallmann syndrome, where the olfactory bulb just doesn't develop appropriately. And then, the talk that I'm going to be giving is mostly focusing on post-viral anosmia. And, there's many different viruses that can cause anosmia. And so much of the research is pre-COVID related when we talk about anosmia and treatment for it. But certain viruses can lead to anosmia, including influenza, rhinovirus, and coronavirus that isn't even COVID related. So when we evaluate these patients, the history is the most important. We like to see if there's any other reason that the patient could have anosmia aside from COVID-19, whether it's allergies or neurologic symptoms, and then we do like to decipher that. From there, we do our examination. In the primary care setting, anterior rhinoscopy it can be very effective. Even if you don't have a nasal speculum, just putting an otoscope with a speculum into the nose can give you a good evaluation of the turbinates, the middle meatus, and can get you signs of allergies or polyps or purulent drainage that could be an indication of sinusitis. In our office, we have the advantage of nasal endoscopy, where we can take a deeper look in the nose. We can kind of look directly at the olfactory epithelium and see if there's any masses, nasal polyps that might be leading to the obstruction of those odorant molecules. And then we also have objective smell testing, which is basically like a scratch and sniff. They smell a series of different odors, and we grade it and find out how severe their loss is, and that gives us a good way of determining their progress when we're treating them. Imaging is always a question when people come in with hyposmia or anosmia. It's definitely, we typically don't need it in post-viral olfactory dysfunction. Sometimes we will consider a CT scan, especially if there's evidence or we're suspicious about chronic rhinosinusitis or other mucosal inflammatory components. And then sometimes MRIs, we think about getting that if we suspect a mass on our nasal endoscopy, or the patient has other neurologic symptoms that might be correlated with epilepsy or multiple sclerosis and things like that. So just a quick general guideline for primary care physicians when they see patients with COVID-19 related anosmia. First evaluate for other neurologic symptoms. As I was mentioning, epilepsy, seizures, multiple sclerosis, things like that. Evaluate for that first, and then, I think in general, if the loss of smell is less than 3 months without any other real nasal symptoms, I think it's okay to consider treatment in your own practice, and we'll go over the treatment in a second. If the loss is more than 3 months, I think at that point, that's when it's good to send it over to us, and we can take a better look in the nose and see if there's any other things that might be causing that smell loss. Smell loss greater than 6 weeks with other nasal symptoms, if they have purulent drainage, they have signs of sinusitis or allergies, you can send them over to us. Obviously, you can send them over to us whenever you want, but this is just a general guideline. So just now going into the treatment, just a treatment overview here. You want to treat any concomitant rhinitis or sinusitis symptoms, and that usually involves, nasal sprays or antihistamines. But the mainstay of treatment tends to be olfactory training, which I'll talk about in a second. Some type of nasal steroids, and typically it's budesonide irrigations, have been shown to be beneficial. And then I'll also talk about some other options that aren't as proven, but there is some research maybe that supports them, and this includes oral steroids, steroid nasal sprays, and certain supplements. So olfactory training is really the most important thing when it comes to post-viral anosmia, and so this is something that I give to all my patients with anosmia. It's low risk. Basically what you do is there are these kits that you can buy online, and they come with 4 essential oils. Those are rose, lemon, eucalyptus, and clove. And what we tell our patients to do is take a deep, slow inhale for 15 to 20 seconds, then they take a 15 to 30 second break, and then move on to the next odorant. They do this twice daily, and they really just focus on the memory of that odor. And this isn't not a quick fix. It's at least 6 months. I usually don't see patients back for at least 3 to 6 months after I start them on this. And so setting that expectation, I think, is important. And basically what we think is happening is that it's slowly kind of regenerating the neuroepithelium and the axons within the olfactory nerve. So, it might sound like hocus pocus, but really there are several studies, including 3 randomized control trials, that show a benefit to olfactory training. And, it's definitely better outcomes in patients who have had the hyposmia for less than 1 year. And so that's a reason, I think even at the first visit, someone comes in complaining about hyposmia, just start them on olfactory training. There's really no downside to it aside from maybe a little bit of time. And it's really probably one of the only things that's been shown in multiple randomized controlled trials to be effective. There's always a question about oral steroids and whether that's beneficial in post-COVID related hyposmia. There hasn't been any randomized controlled trials that have been done to evaluate oral steroids in patients with post-viral hyposmia. And the studies that are out there are kind of typically case series or smaller patient populations. And there's really no good evidence to support routine use of oral steroids in post-COVID hyposmia. There might be a little bit of data to support giving steroids very early in the disease process, so maybe within the first 1 to 2 weeks if you catch it. But there's always the downside of steroids, and like I said, 85–90% of patients will eventually recover their sense of smell. So there's always a risk-benefit analysis if you do catch it early. But typically, if it's a week or 2 out, then I don't think oral steroids are necessary. Topical nasal steroids, on the other hand, I think do play a role in post-COVID hyposmia. The only nasal spray, and there's a specific nasal spray that's been actually studied in post-COVID anosmia, is mometasone furoate, which is Nasonex. And in this study, they took Nasonex plus olfactory training and compared that to nasal saline with olfactory training. And it was a randomized controlled trial with 77 patients. And what they found was that the Nasonex group had 2 times more patients return to normal sense of smell at 4 weeks. So that type of nasal steroid, I think, is reasonable. And then the other thing that's been shown also to be helpful, but this is not in COVID-related patients yet, I know they're doing some studies, but is budesonide irrigations. And that's where you take like a neti pot or a sinus rinse and put a steroid into that. And kind of flush your nostrils. And the hope is that it kind of gets deeper into the nose and in towards the olfactory epithelium and has an effect in that way. So there is a randomized controlled trial, again, not COVID, but it is post-viral anosmia. And they compared budesonide irrigations plus olfactory training and they compared that to saline irrigation with olfactory training. They had 6 months follow-up in 122 patients. And there was a 27% improvement in the saline group alone, but there was a 44% improvement in the budesonide group, and that did reach clinical significance. So what I usually say is the budesonide, I think I prefer that only because it's kind of a deeper action, gets deeper into there. And if for some reason they don't like to use steroid irrigations or they don't like irrigations, then I'll mention the Nasonex to them. Some other therapies that just aren't really supported by that much research, but I think something to consider in COVID-19, there's a higher level of TNF alpha in the olfactory epithelium. And so there's some supplements that have been shown to decrease levels of TNF alpha in various inflammatory syndromes, not COVID specifically. So this includes omega-3 fatty acids, vitamin C, D, and E. I'll talk about that in a second. The other one is intranasal theophylline nasal spray. Theophylline is a chemical or a compound that increases CAMP and CGMP, which, increasing this within the olfactory epithelium helps to increase the production of olfactory receptor cells. So there is some data, it's pretty limited, that shows that this can help some patients with just hyposmia in general. Again, it's not post-COVID related, but there is actually an ongoing clinical trial right now that's comparing intranasal theophylline nasal spray in post-COVID related patients, comparing it to nasal saline. So that should come out in the next couple years. But going back to omega-3 fatty acids, there is some data here, but it's mostly in post-surgical patients. So there was a randomized controlled trial with 87 patients after endoscopic skull base surgery. And as I mentioned, a lot of times these patients will have transient and rarely permanent smell loss. And in this randomized trial, they compared postoperative saline rinses versus saline rinses plus omega-3 fatty acids, so 1,000 milligrams BID. And what they found is that the saline rinse-only group, 26.8% of the patients continued to have clinically significant smell loss at 6 months of follow-up, whereas the saline rinse plus the omega-3 group, 93.5% of them returned to baseline smell in 3 months only. So they got back to their baseline pretty quickly. And omega-3 fatty acids, again, are low risk, so I do think at least offering it to patients is reasonable. So this is my kind of practical approach to post-COVID-19 hyposmia. Of course, treat any rhinitis or sinusitis symptoms, whether it's with nasal sprays or antibiotics if needed. Olfactory training, definitely start this early. It's data showing that it's better if you started early. Then it's either budesonide irrigations or mometasone nasal spray, plus or minus omega-3 fatty acids, as I mentioned. I think it's important to reassure patients with, especially those that are depressed. And then you have to set reasonable expectations. This isn't going to be something that works in a few days or even a few weeks or months. A lot of the data is, 6 months, 8 months, 1 year. So it's going to take them some time, and as long as they're consistent with it, a lot of the data is showing a benefit. And so after that, I usually follow up in 3 to 4 months to assess how they're doing. So just in summary, many cases of COVID-19 are associated with transient smell loss, although it is less common in the more recent variants. About 5 to 10% of patients will develop long-term olfactory dysfunction, and olfactory training should be initiated in all patients. Budesonide irrigations or mometasone nasal spray should be considered, and then consider an ENT referral if the smell loss is longer than 3 months, or if there are any other concerning nasal symptoms, or if there are any questions at all. Thank you. Any questions on that?
How do you instruct them to do the budesonide irrigation exactly?
Yeah, so we tell them to either get a neti pot or a Neomed sinus rinse. They fill that with either distilled water or filtered water, like usual. They dump in this. Oh, sorry. The question was, in terms of the budesonide irrigations, what exactly do we tell patients on how to use it and what's the proper way to use it? So, yeah, basically you take the neti pot or the Neomed sinus rinse, fill it up with normally like you do with either filtered or distilled water. You dump in the salt packet like it comes with, and then we give them basically a compounded capsule or an ampule of budesonide. It's usually 0.6 milligrams to 1.0 milligrams, and we just tell them to open that up and dump it into the saline irrigation and shake it up, and then flush their nostril one side, half the bottle on one side, half the bottle on the other side, and we tell them to do it twice a day, typically.
So they can only get that at the compound pharmacy then? We can't really prescribe it?
You can prescribe it, but you just have to prescribe it to a compounding pharmacy. Yeah. Yeah.
Oh, at one time they used to talk about zinc. Does zinc do anything?
Zinc in research, like randomized control trials, there isn't much there to support it. But I think zinc is a reasonable thing to try because it's relatively low risk and it's anti-inflammatory. But there's not like research to back it.
So, Dr. Anwar, if you had a patient with post-traumatic olfactory dysfunction, not just post-surgical, but let's say closed head trauma, whiplash with potential shearing, would you treat them the same way as the post-surgical patients?
I think those patients, it's a lot less likely that they're going to regain their smell function because there's been, an anatomic severance of their olfactory bulb and their neuroepithelium. So I think in general, treating them the same way is reasonable, but I would set their expectations maybe a little bit lower. Yeah.
That's the same question. Would you treat, let's say you see a patient comes in and acutely with trauma and loss of smell, would you put them on a steroid or something to reduce edema or anything? Or does that occur that much?
Yeah, I think if it was acute, like if they came in within a week or so, I think I would start oral steroids in them to give them the best shot at getting back their smell function. Yeah, but I would also do the other stuff that I mentioned. Yeah, yeah.
Thanks a lot. That was excellent. So two quick questions. So one, when you say steroids, what type of steroids?
I typically use prednisone, and when we do this, if we give it, I'll give it like a good dose. So start off at like 50 or 60 milligrams, and then start that for a few days, and then taper down from there.
Okay, so we're just to clarify for the audience, we're talking a pretty significant dose of steroids for usually about a week or two taper, not a Medrol pack, especially if you're trying to recover from acute anosmia. And then the second question is, taste is also associated very much so with smell function. Has there been any evidence to suggest that there's anything to do to help patients who have taste disturbance following COVID or in recent literature? Is that still something that's ongoing?
It's still something that's ongoing. I think a lot of it, they're kind of correlated, smell and taste. So a lot of it is if you focus on their smell, which is I think a little bit easier to focus on, and there's research behind it, a lot of those patients will get their taste function back. Taste is a tough one, I will say that.
So one of the pieces that is a great talk for compliance, when you look at the studies, the results reflect that the patients are compensated, so they are compliant. So how do we get patients to be compliant with olfactory retraining and visual analog stimulation for 6 months? And what I tell them physiologically is the olfactory system is a very unique system. It is one of the two reservoirs of neurogenic stem cells. So in the olfactory bulb, nature put neuroepithelial cells to regenerate smell. And that regeneration is possible if you continue to ping it. And I tell them, listen, you can get your smell back if you do this visual analog retraining. And as Dr. Abbas said, you have a patient put a rose in front of them, and then they smell the rose, and they're looking at the rose, and they're pinging the memory of what a rose smells like by looking at it while they're stimulating chemically the olfactory. Same thing with the lemon. I have them put a lemon in front of them and have them stare at the lemon while they're actually smelling the smell. So in that, you tell them it is possible, but you have to do it. I can't tell you how many patients will come back, yeah, I tried it for a couple of weeks, it didn't work. And then what's next? Well, keep doing it for 6 months, but but if we compensated them, they do it.